And today we're going to talk about a specific condition which is very, very important from a pediatric endocrine perspective, though it's a rare disorder. So how common is Prader Willi syndrome, Sayan, according to you?
So generally it is 1 in 25,000.
So it's around 15 to 25,000 is what the figure is quoted. But if we talk about a pretest probability of Prader Willi syndrome, let's say most common situation that an endocrinologist will think of Prader Willi syndrome will be obesity. How common is Prader Willi as a cause of obesity?
As a cause of syndromic obesity, very less than 2 to 3%.
So syndromic obesity, it is the commonest syndromic cause, but overall prevalence will be very, very minuscule. So most cases when you are thinking of Prader Willi syndrome, you do not get the diagnosis. What would be the things which will increase the pretest probability along with obesity?
The specific clinical features, like you get like hypotonia.
Which is the most specific clinical features? Which is the highest positive predictive value? Hypotonia is the most common one. And if you look at infantile hypotonia, how many of infantile hypotonia who have severe ones will have Prader Willi?
Almost.
No, not 80%, 20%, 10 to 20%. So if you have significant hypotonia, and we'll discuss about what significant hypotonia is, and that's manifested antenatally also. How can you think of antenatally that this could be Prader Willi syndrome?
Sir, antenatally, the manifestation of hypotonia, which is basically decreased fetal movements, polyhydramnios, and in case.
So decreased fetal movement is a subjective thing, common. Anything specific on ultrasound?
The polyhydramnios and decreased.
So what people say that because tone is less, there will be a flexing of the limbs. So that could be a characteristic features. So most specific manifestation of Prader Willi syndrome will be hypotonia. It's pretty much universal. If you go back on history, you will find hypotonia, motor developmental delay, and then hyperphagia. But many of these cases, the classical manifestations may be absent. So we will be focusing about a child who is diagnosed very late. The usual age of diagnosis of Prader Willi syndrome in US now, the mean age is in the few months age group. That is because they are picking up infantile hypotonia. If you pick up hypotonia, you can immediately diagnose that. All other features are non-specific. So if you look at obesity, growth failure with obesity, almond-shaped eyes, acromicra, they will not be very, very specific. But we are picking up most cases around 10 years, 12 years, something like that. There is also a window of opportunity. If you act early, you can prevent complications. Otherwise, there will be a lot of issues. So we'll be dealing with a very challenging case of Prader Willi syndrome in which there were a lot of complications which were there. And that really resulted in a lot of evaluation, assessment, management issues, which we'll be discussing. And then we'll use that case as a template to discuss about how we should have managed it appropriately at the right time. Age-specific evaluation and management is what we'll be focusing about. This was a child who had come to me at 7 years of age with rapid weight gain. So again, the same history. There was infantile hypotonia. The child was growing not well, and he was already 42 kgs. So the BMI was pretty much high at that point of time. He had that typical features. There was hyperphagia, developmental delay, behavioral abnormality. So this is something which is also very common, that behavioral abnormality will be important. Now, basic workup was normal, and child actually had classical features of Prader Willi syndrome. And I'm not showing the face here, but they had all the classical features. So this was diagnosed at 7 years of age with these problems. So what would you like to do at this point of time, Vibha, if you diagnose somebody at 7 years?
So at the 7 year of age, we should assess for the pivotal status of the child for the management purpose.
Yes.
Regarding obesity, weight control, dietary,
and the height is also less. So if you look at FDA recommendation, we talk about obesity with growth failure. The general consensus is that any child with Prader Willi will improve on growth hormone, even if they don't have growth failure, because they will ultimately have growth failure. So we at this point of time advised him that he should go ahead and FISH study. At that time, it was like 15 years ago, we got a FISH, it was positive for Prader Willi syndrome, was advised growth hormone. But the problem was this child did not take growth hormone. Now he came 10 years later on with a weight of around 125 kgs and had developed frank type 2 diabetes. So this was a scenario where we could have prevented this complication from happening if we had given right treatment, right assessment and management at that time. That's why early diagnosis is an important phenomenon. The other basic issue is the challenge of diagnosis. Now, what we often see is that the tests we routinely do, FISH, methylation, even other PCR, often the results are negative. So that is a very confusing scenario. So this we'll be discussing specifically. Naveen will focus about that in that detail. So this is an interesting thing. So Prader Willi syndrome overall is common, 1 in 15 to 20,000 live births. It may be missed because many milder cases may not be missed, like we missed Turner syndrome also. In that perspective, an early intervention is essential in that setting. It's basically a methylation defect, and we'll discuss in detail about what imprinting, methylation, all those things are in that regards. All of you can have a look at our website, learning.growsociety.in, which has got a lot of innovative tools for training in pediatric endocrinology, along with courses, fellowships, and diploma courses. We run 3 modules in the form of grand rounds as well as postgraduate lecture series every month, which you can access through, along with our publications and the mobile application which is there. So today we are going to talk about a specific topic, and we'll use only one case. Normally we have a spectrum of case, but this case actually in itself had all the findings. So this was a very good case which we managed recently with the pediatric unit in the intensive care.
So we have 7-year-old male child who was born out of non-consecutive marriage, and patient was admitted in PICU with pneumonia and referred to endocrine unit with the chief complaint of pneumonia, and referred for the management of the hyperglycemia with the background history of diabetes and severe obesity. So at the present history, the child was apparently well before 6 days, and child developed pneumonia since 2 days and shifted on non-invasive ventilator support because of the O2 saturation went around 69 without O2. RBS was high, that was 240 milligram per deciliter. So any sick child with the background history of diabetes, we can first thought in the pediatrician mind it could be the diabetic mellitus, decay, but patient having blood gas showing, patient having respiratory acidosis, which was compensated by metabolic alkalosis. So it was a very opposite picture of the decay.
What was the CO2 levels?
Sir, PCO2 level is 69.
69, and they went up also. The levels I think went up very high. So this
in follow, it went to up to 85.
85. So this is very, very clear that this was more like a type 2 respiratory.
So
this was not a ventilation problem. This was more like a problem in terms of, this was more of a ventilation problem rather than an alveolar problem. This was not just a pneumonia. There was also an underlying ventilation issue which was there. So CO2 was very high, and bicarbonate was I think 35 to 40.
So bicarbonate is 42 at initial.
So which means it was a acute or chronic compensation?
So that means we are patient having a chronic respiratory acidosis, which is compensated by chronic.
Yes, so this was a classical giveaway. See, if you saw the child, you know the diagnosis, but even if you look at the blood gas, it is definitely not going to decay. Suppose he developed decay, what would have happened?
Sir, a patient have decay, then
suppose this sort of a child whose CO2 is already sitting at around 80, develops decay, what will happen?
Then CO2 will come down.
He cannot take out the CO2, that's the whole problem. He will be in a very, very bad shape. He is normal because his bicarb is 40. If his bicarb becomes 10, he will be no more. His pH will be very low. So if they develop acidosis, that would be a huge problem. So if somebody who is hypoventilating has decay, then this is like a very, very critical situation. Any other cause of acidosis might happen in this scenario. Suppose some treatment was being given which would have caused that.
Yes, sir. Child having background history of diabetes. So if child was started on metformin, so it can precipitate metabolic acidosis.
So that's another message. And this child was, I think, on metformin.
Sir, child was on metformin.
Child was on metformin, which is actually contraindicated if you have a respiratory abnormality because of the risk of lactic acidosis. So key message, if you have Prader Willi syndrome with diabetes, avoid ketosis at all costs, because that is going to cause a huge problem in this scenario. Can you?
So and ketone was not.
Now let's come to that. Now coming to another interesting question. Do you think Prader Willi syndrome will be more predisposed to decay or less predisposed to decay? Suppose they develop type 1, and we know it's type 2, but type 2 can also develop decay. But let's say there is insulin deficiency. So would Prader Willi be more predisposed or less predisposed to decay compared to another child, same child, similar child?
So they are less prone.
Why? Science?
So the cutting down of fat is very decreased in these cases.
Why?
So the ketosis will not occur.
Why?
So physiologically, or exogenic pathway is stimulated in these patients.
What causes decay? Insulin deficiency? And what happens to counter-regulatory hormones in Prader Willi? GH is deficient, cortisol is deficient. So effectively, they behave like hypothalamic defects in GH everywhere. So because they don't produce, your point is right, their fat is more because they don't have growth hormone. Growth hormone is not going to cause lipolysis or when you have ketogenesis. So they will have less chance of decay. But if they develop decay with hypopnea, that is going to be a very, very devastating scenario.
So ketone was also normal, so it was not decay, and child having BMI was 41.1 kilogram per meter square, which was showing severe morbid obesity.
How do you define morbid obesity?
Sir, if it is BMI is more than 40, then it is a morbid obesity. If it is more than 35 with complication, then we can define.
Is this criteria for children or for adults?
So it is Prader.
So in children, the criteria would be not valid, but definitely it is very significant.
Child was on oral hypoglycemic agent since last 2 years and on levothyroxine since 3 years of age. So,
so when we talk about levothyroxine treatment, what sort of hypothyroidism will happen in Prader Willi syndrome?
Sir, mainly in Prader Willi syndrome, there will be central hypothyroidism.
Will you be more likely to miss it or diagnose it?
Sir, we will easily diagnose.
What will happen to TSH?
TSH. So leptin will be high. So TSH would be high.
So you may actually diagnose it as primary hypothyroidism. Your TSH may be falsely high in Prader Willi syndrome. So your it is central. It is not even. It is tertiary. It is hypothalamic. TRH is less. TSH should be less. But then somehow your TSH may be falsely high. So this is often a confusion when you label them as primary hypothyroidism. They actually are central.
And how to differentiate?
You don't see if it again the same message. TSH should be should be more than 100 if FT4 is low, generally speaking. So if your TSH is 15, 20, 25, then think more of central. So what I'm trying to say is that before you do that, you have to look at cortisol. Definitely, because they also have cortisol deficiency.
Okay. So my patient having significant history, which was started from the birth. So I would like to start my history from the birth history. So birth history, child was full term, appropriate for gestational age, born out of LSCS, patient due to the patient having fetal bradycardia and non-progressive labor. Birth weight was 2.75 kg and child having delayed weak cry. Child was admitted in NICU for 10 days and child had neonatal jaundice in NICU. In infancy, according to mother, child having typical weak cry, child was lethargic, not able to move also, and child having poor muscle tone. There was no any history of vomiting or feeding difficulty, and child weight was normal according to age in infancy. And child had started crying after 1 year of age and sitting at 14 months of age. After this initial delayed milestone, afterward the milestone was normal. And in childhood period, child started gaining weight at the 3 year of age. At the 4 year, child weight of child was 40 to 45 kg.
So this is a classical textbook story of Prader Willi syndrome. There was issues in terms of weak cry, hypotonia, non-progressive labor that may also be part of the hypothalamic dysfunction. and the hypotonia, then hypotonia, hyperphagia, and increased risk. What are the features which will suggest that this is hyperphagia, pathological hyperphagia?
So pathological hyperphagia, according to the history.
Yes. Not in this. Suppose you want to ask a history of hyperphagia. So what will you question you will ask?
So he, after having food, he'll ask for more food, or he'll have food from the other plates, or he have food seeking behavior like those.
Even from
like from
waste food, garbage, lot of people. So severe hyperphagia may come like that. So that is the specific leading question we will do. Nighttime bakery
and child diagnosed with the hypothyroidism at 4 years of age. So initial TSH and T4 report was not available. And child had hyperphagia in term of irresistible food urge, craving for food at night time. Child had behavior abnormality like temper tantrum, and child was aggressive in behavior. Diabetes was diagnosed at the 10 year of age. There was no decay at the onset, and child was managed by sulfonylurea, SGLT2 inhibitor, DPP4 inhibitor with metformin, and blood sugar was under control since 2 years.
So what is the main cause of diabetes in Prader Willi syndrome? It is?
Sir, it is mainly due to the obesity. Second,
insulin resistance basically. So out of these drugs, which one do you think are suitable and which one are unsuitable?
Sir, as we discussed, metformin we can't start because there is a respiratory muscle tone was less, so child having more.
So metformin should not have been given. Sulfonylurea?
Sir, sulfonylurea also can cause weight gain, so we will generally avoid this. And we
also too young, and it's more of an insulin resistance. DPP4 inhibitor?
Sir, DPP4 inhibitor means some role will be there because it will inhibit it will inhibit GLP-1 analogs degradation, so it can help at some point. But it is
not as potent. It is a different mechanism. The mechanism of GLP-1 is more towards satiety, more towards gastric emptying. DPP4 is more like imprinting, pure imprinting. So when you eat, then only that GLP will come. That GLP otherwise will work on the brain is different. So this doesn't behave like GLP-1. So it is a weight neutral drug. But it may increase insulin. It may also have an effect on alpha cells. So glucagon may come down. So that may be a SGLT2. So
SGLT2 we can start because it can cause weight loss or reduce BP.
But again, at 10 years,
we can start.
Indicated.
Okay. Child was not able to do any complicated task in classroom like maths sum, and child having increased pain threshold during the illness or during any trauma.
This is very, very important that they will not having any significant symptoms, they will not express. What happens to the gastric motility?
So the gastric motility will reduce.
So suppose you have a child who has come to with mild abdominal pain, vomiting and distension. What could be the basic cause?
Sir, mild abdominal pain, vomiting. It could be the gastritis, or it could be the overeating, because of the overeating, because they don't have any pain sensation. So while they have episodic diarrhea or gastric.
So severe gastric dilatation may happen without any symptoms. So this is very important. So they will have reduced pain sensation and they have hyperphagia. So normally if you eat too much, there will be pain and you will have symptoms of obstruction, dilatation, you will stop eating. But there is a known complication, severe dilatation may happen in Prader Willi syndrome because of this pain issue.
So there was no any history of weight gain and hyperphagia during infancy, which is ruling out leptin deficiency. There is no any history of chronic drug intake like steroids, and there is no any proximal myopathy violaces prior to ruling out Cushing's syndrome. There is no any history of vision, hearing, renal, digit abnormality to ruling out other syndromic abnormality like Elstrom and Prader-Willi syndrome. There was no any brachymetacarpia or subcutaneous calcification to ruling out pseudo-hypoparathyroidism. There was no any history of hypotension, hypoglycemia, and depigmented head to ruling out POMC or proconvertase deficiency. So family history, there was no similar family history is present in family. Parents having diabetes mellitus and hypertension, but the parents was not that obese. Child having one sibling, age of 22 year now, he was absolutely normal, and there was no any significant sibling history, and mother and father having normal height. So there was no any pointer towards the.
What are the chances of recurrence of Prader Willi syndrome in this child?
Sir,
Sibling.
So it depends upon the what kind of genetic involvement is there. If it is an imprinting disorder, then it can chances of the recurrence will be there. Otherwise, in paternal deletion and UPD, the chances will be not there.
99% of cases, the risk is very less, less than 1%. Only if you have a imprinting center deletion, that is a 50% chance. And rarely you can have other scenarios where there is a translocation of chromosomes. Then you have around 25%.
25%.
So that will be the situation.
But it transfers up to 99%.
So,
variables.
yeah. So basically, the overall risk is less than 1% in most cases. And what is the history of this pair complexion? What does it mean?
Sir, means child is. This I didn't get. Sir.
So you took the history.
Yes, it was means child was apparently looking fair in comparison.
Why? They are hypopigmented. There are some of the genes in that particular region have a pigmentary issue. So they are hypopigmented. This is one known feature of that.
Anything to do with the anorexic pathway MC4?
No, that's a different thing. They have a specific region, those genes. We discussed about that.
So child has a fair complexion in comparison to parents. Developmental history, initial milestone was delay. Afterward, the milestone was normal. Child had started walking at the 2 year of age and running at the 2.5 year of age, but child was not doing any complicated task in classwork. So by the anthropometry, height was 139.5 centimeter. That was minus 2.46 standard deviation. Weight is 80 kg plus 2.18 standard deviation, and BMI was high, 41.1, which was showing 3.3 standard deviation. So if we interpreted this anthropometry, then we are dealing with short obese child. Generally, if it is normal physiological obesity, then child should have height should be taller. Child should be taller in the height because of the high IGF-1 level in blood, but this child was short, which was pointing towards the endocrine query syndromic obesity, but there was no any pointers towards showing endocrine obesity. So mainly we are dealing with the syndromic obesity or monogenic obesity.
So what do you expect the growth hormone level in a normal exogenous obesity?
So normal exogenous obesity growth hormone level will be low and IGF level should be high.
And Prader Willi?
In Prader Willi, both are low. Growth hormone will be low and IGF-1 will also be low.
And the growth hormone will be more low. It will be falsely exaggerated. So TSH basically tends to in hypothyroidism, we have discussed central hypothyroidism. Central hypothyroidism, we expect the TSH to be falsely high. In growth hormone deficiency, growth hormone will be further low. So their deficiency will be exaggerated because of obesity. What about cortisol? So I've talked about that you overestimate GHB, you underestimate central hypothyroidism. What about cortisol?
So cortisol levels will be low.
Yeah, they are low. So they have hypothalamic dysfunction. GH, cortisol, gonadotrophin, everything is low. But as compared to because of obesity, what do you think will happen in terms of cortisol? Simple other question is this.
So cortisol levels will be high in case of obesity.
So they will be falsely normal. So you will falsely have normal values of TSH and cortisol and falsely much lower value of both. That is important for that perspective.
And child having prepubertal status, micro SPL was 1.5 centimeter and testicular volume is around 1 to 2 ml. So child having micro penis.
Was there pubarchy?
So there was no pubarchy.
Can you have pubarchy in this children?
Yes, if it is not associated with the ACTH deficiency, then it should be the pubarchy will be there.
So Prader Willi, often they come to us with disconnect between gonadarchy and pubarchy. That we talk about obesity, we talk about pubic hair is there, but testicular volume is low. This is the most classical example. they will have undecided testes also for years. Often they will have undecided testes and very small size, but puberty will happen because of it. But if you have complete like he had so many things, his hypothalamus would anyway be knocked out in that scenario.
So this is the picture of patient. Because of the identity purpose, I am not showing eyes, but patient having narrow bifrontal diameter and child having typical almond-shaped eyes. And there was, as we are seeing in patient, there was central obesity. Patient having acromicra, short hands, and there was a micropenis. SPL was 1.5 centimeter, and as we are seeing in the picture, in thigh also there was a severe obesity. And child having typical light complexion in comparison to parents. So patient having thin upper lip, and there was almond-shaped eyes. In this picture, we are clearly seeing there was a narrow bifrontal diameter, and there was a downward tilted lower lip was there. And apart from these facial features and the physical features, there was also behavior abnormality which was suggestive of hypothalamic obesity, like temper tantrum, aggressive behavior, snoring at the night time, daytime sleepiness and lethargy. There was a high pain threshold and decreased attention span in class. So in hospital history, child was admitted in PICU and managed with the non-invasive ventilator, and had a hyperglycemia which was managed by insulin infusion, SOS, and shifted on the subcutaneous insulin. Child had one event of desaturation during sleep, and which was which was started on the CPAP during night time in the ward. So we had a thought of sleep apnea. So we did sleep study, which was suggestive of moderate sleep apnea. Apnea hypoapnea index was 9.7 times per hour. For any children, for the children, if AHI index is more than 1, it is a very significant. For adult, AHI's index more than 5, we have to be worried. So in this patient, it was more than 1, 9.7. So child was in moderate category with, and one time O2 desaturation went up to the 71%. So child having significant sleep apnea was there. Systemic examination was normal, which we did at the time of discharge. And by the summary, we are dealing with 12.7-year-old male child, who having a severe obesity with growth failure, who having syndromic faces, and who having moderate sleep apnea, associated with the hypothyroidism and diabetic mellitus, with micropenis and normal to low IQ, with the background history of infantile hypotonia, hyperphagia, and behavior issue with no history of brain infection, trauma, or surgery. So which is ruling out any secondary cause of hypothalamic obesity. So therefore, we are dealing with the case of syndromic obesity with a short height, most probability of Prader Willi syndrome. So by investigation, blood gas was showing PCO2 was 67 and bicarbonate was 42. So it was clearly suggestive of patient having chronic respiratory acidosis, which compensated chronically by metabolic alkalosis. HbA1c was not that much elevated, 7.9, and 2D echo was normal. Sleep study, as we discussed, suggestive of moderate sleep apnea, and CBC showing mild anemia. So our diagnosis was regarding this patient phenotypically, patient having syndromic obesity, possibility of Prader Willi syndrome, which was associated with the type 2 diabetes, with hypothyroidism, with moderate sleep apnea, presented with the type 2 respiratory failure. So by the treatment, we prescribe injection insulin for the hyperglycemia management, home CPAP at the night, levothyroxine for hypothyroidism, plan for growth hormone therapy after ENT reference. But we have severe obesity, uncontrolled sugar, and sleep apnea. So we have planned to start growth hormone therapy after resolution of these complications, and advice for close monitoring for sugar control and for the sleep apnea. A patient came for follow-up after 1 month, which and the patient's weight was significantly reduced. Patient has reduced weight around 10 kg in 1 month, and now he is able to control his appetite at some extent, according to mother. sugar level was normal. So we were planning to start GLP analogs for the obesity and diabetes management with tapering of insulin.
So this is basically a imprinting disorder. So when we talk about imprinting disorder, it means that this is a disorder in which there is a variation in phenotype depending upon whether you get the inheritance from the mother or the father. Simply put, in body, there are two types of genes. One genes in which both parents' alleles are working by allelic expression. Some genes, it is only monoallelic. So either the father's is working or some the mothers are working. So imprinting disorder simply means that this is those particular genes which are there in which only one parent's genes are active. So this is example of imprinting disorder. And what are the other common causes of imprinting disorders other than Prader Willi? Yes, and growth failure. Angelman is opposite to this Prader Willi. Then growth failure. Which one? Russell-Silver syndrome, with Beckwith-Wiedemann being the opposite of that. Then paraganglioma syndromes. So a lot of other syndromes are also associated with precocious puberty. And in fact, a lot of these genes are clustered. So they will be together, close to that in that regard. So a lot of these conditions are imprinted in that setting. So Prader Willi is basically an imprinting defect. The problem in Prader Willi is that this region, 15q11.2q2, which basically means the long arm of 15 chromosome, this particular region, only the father's genes are active. So if your father's genes are not there, you will develop features of Prader Willi syndrome. While in this region, some other ones which are mother's genes are active, if that becomes defective, you will have the opposite picture, which is known as Angelman syndrome. So essentially, the scenario here is that in this region, 15q11, you have got a specific types of genes which encode for small nucleolar RNA. Now we know that there are multiple types of RNAs. Now, snRNAs are ones which are more of regulatory functions. They are not translated, so they are not like messenger RNA, but they guide the whole process of translation in that regard. So they are important in that setting, and they also help in post-translational modification. We discussed in collagen, in TSH, in LH, that post-translation glycosylation and other factors are also important determining a biological activity of a protein. So they are very important from that perspective. Now, this is not a single gene. So of course, this is not a monogenic defect. So this is a whole region which is affected. Depending upon how many genes are affected, the phenotype will be variable in that regard. So there are multiple genes which are there, especially MKRN3 is very, very significant, which is for the pubertal onset. There is also one which is dealing with pigmentation, and there are other features there, and MAGEL2 also is associated. So Prader Willi syndrome is a, theoretically we can say it's an imprinting disorder in which a group of genes are affected, and that's the clinical scenario. So defect is, as I said, 1 in 20,000. Most of them have deletion of the father's gene. Some, there is a duplication of mother's gene, which is uniparental disomy, or rarely methylation studies. Now, this condition, which we'll discuss more in detail, is associated with increased appetite because of ghrelin and reduced activity of BDNF in that scenario. Manifestation we've discussed: hypotonia, growth failure, hyperphagia, and increased pain threshold in that scenario. So let's go one by one. If you have a paternal deletion, what will happen? You've got only one copy of the gene which is coming from the mother, and these genes are sleeping. So how do we get imprinting? Imprinting basically means that you have switched off those genes. So they are sleeping in that scenario. So the defect is in the paternal allele, most common form. Now, how will the manifestations be? Naveen, what do you think about these cases?
So the most severe of all these types of genetic.
So this is, of course, the worst of all scenario. They will be the most severe disease, and fish will give you a diagnosis because this is deletion. So 60-70% cases fish, and you will discuss more in detail that how fish will help, but this is a scenario you will get the diagnosis immediately. The recurrence risk will be very, very low. Now, if you have duplication of the mother's gene, which is uniparental disomy, what it simply means, it is a complicated term. It basically means that both alleles are coming from a same parent. Uniparental disomy. So the one was deletion, so you had only one copy which was sleeping. Here you have two copies, both are sleeping. So here the problem would be that both the genes are coming from the mother, So this is another important thing, and now it is being recognized more in clinical practice because we have got better genetic tools which are there. Now, what about the manifestations of UPD? Would they be more?
So less
But which symptoms are more common?
the behavioral side.
So often we tend to see that they have got a greater amount of issues with regards to attention deficit and autism-like features which are there. And these features are important to evaluate and assess in that perspective. The next is the imprinting center. Now, imprinting center, basically what it means is that there is a center which is located proximal to this particular gene which regulates imprinting. So if your imprinting center is defective, what will happen is that your father's gene may be falsely imprinted. So it is not going to be expressed. So here the problem will be in the imprinting center. What do you mean by epimutation? Vibha.
Silencing is basically methylation of the.
So it is another epigenetic. So you do not have any change in the coding, or the sequence is the same, but the sequence is not working. So this is a very, very cryptic scenario. What happens is that your coding genes are already there, but they are silenced. Once they are silent, then the methylation will also be affected. So this form will be the most difficult to diagnose, and this will Naveen will talk about. Sequencing will be normal in this scenario. Manifestations are the recurrences will be less because this is of course a specific problem and that particular child, similar clinical features to the other one. If you have imprinting center deletion, now this could be the next scenario. The center is not there. Now what will happen in this scenario? Again, you will have an abnormality which you can pick up on a sequencing that is there. But why is this one relevant to identify?
Because there will be chance of recurrence.
And recurrences could be very, very high. You may have up to 50% recurrences also. So that's what question we were asking. Depending upon the genetic defect, your risk of recurrence will be more in that scenario. Now, if you have a paternal translocation, what do you mean by translocation, Naveen?
So there is one chromosome. There is an exchange of genetic material between two chromosomes.
So this chromosome from the 15q11 goes to somewhere else. So that is going to cause a confusion because then the whole imprinting thing will become absurd in that sense. So you have got this, the entire genetic material is the same. One goes to the other side. So it's a right thing at the wrong place. This is what you can talk about translocation. So here you have a balanced translocation, again rare. Manifestations, they have a recurrences which is high and it will vary upon depending upon how much your inheritance has. Clinical features, there is no difference. So broadly speaking, if we talk about genetic basis, the most common is paternal deletion. This is what is the classic. So when we say classic Turner, we were saying X0. Same, you have got this classic phenotype, which is the most severe one which is there. But what we need to understand is that there may be milder phenotypes of Prader Willi. So you don't need to always have all these facial features that we discussed because these will be the most severe cases. So in those scenarios, you can look at other ways to identify. That will be the maternal UPD. Imprinting epimutation, again, milder forms, methylation study will give you a clue. Deletion, PCR will give you identification, and finally balanced translocation, difficult to identify, but high risk of recurrence in that scenario. Now, in terms of pathophysiology, this one I alluded when we were discussing what happens to the hypothalamic axis. So we all know that obesity, growth hormone levels are low, but IGF-1 are high. But in Prader Willi syndrome, the problem is in the pituitary or in the hypothalamus. It is mainly in the hypothalamus. So it's a hypothalamic defect. So your GHRH will be low, GH will be low, and IGF-1 will be low. So this is important. So if you're doing growth hormone stimulation test in that setting, it is very likely that it will be abnormal. But you will exaggerate the diagnosis of GHD because your GH will be further low because of obesity. So you will exaggerate the diagnosis. TRH will be affected, TSH will be low, but again, this hypothyroidism is central, but your TSH may be slightly more. So what I'm trying to say is that if you have a central hypothyroidism because of a normal scenario and central hypothyroidism due to Prader Willi syndrome, TSH will be higher in Prader Willi syndrome. That's it. It doesn't mean that TSH will be very high, but it may be slightly higher as compared to the other scenario. What about CRF? CRF is also on the lower side. And because obesity causes hypercortisolism, you may actually have a confusing scenario. But very importantly, when you're starting thyroid in this scenario, you're starting growth hormone in this scenario, do a cortisol level, maybe do a GnRH, ACTH testing before you start treatment in those situations. What about GnRH? GnRH is also affected, and we all know that there is hypogonadism. LH is low, testosterone is low. But what about FSH? Naveen? Because there is both central as well as peripheral problem. So interestingly, you may get a scenario where FSH may be high. So this is what you need to understand. In boys, typically they will have severe delayed puberty, micropenis, undescended testis. Puberty may not have any onset, but pubarchy may happen. They will always be infertile. Fertility is not there in males with Prader Willi. Females, they will have severe, because of obesity also you will have a problem. They will have amenorrhea. They may not have periods for 30 years. Pregnancy may rarely happen, but obesity per se will cause a problem. Now, my question to Vibha is, what will obesity do to LH and FSH level? Why?
So
you will have more estrogen because of the fat. Estrogen will suppress, so you will have low. So in morbid obesity in males, you have got hypo, which happens. So again, this is going to worsen in that scenario. So growth hormone axis, we all know that growth hormone levels will be on the lower side. IGF-1 levels will also be low. It's a hypothalamic defect, and therefore there will also be confounding effect in terms of growth. So giving growth hormone in this scenario will be effective. You do not need to do a growth hormone stimulation test in this setting. Now, why are they obese? So the problem is largely at the level of ghrelin. As I discussed, there is also an issue in terms of satiety. So there are two things. One is more appetite and second is low satiety. So other mediators are pancreatic polypeptide as well as a role of BDNF pathway, which is there, but mainly ghrelin is there. HPT axis, I said GnRH is low, LH is low, testo is low, but FSH may be high. So you have this both central and peripheral picture, which happens. There is a disconnect between pubarchy and gonadarchy, and you can often have undescended testis and infertility. Scenario, SNRPN gene. Dr. Fahimida Zabeen from Bangladesh, one of mine, 8.5-year-old girl with morbid obesity and diabetes on oral and insulin, also diagnosed with leptin deficiency abroad. Is there currently available treatment to address a leptin deficiency? So leptin treatment is available, recombinant leptin is available, but it's very, very expensive and not routinely available. So special programs are there through which it can be there, but again, very difficult to identify. How much does MLPA cost? 8,000 rupees, I think is the cost. So it's a good investigation. We have been struggling a lot with regards to many classical features of Prader Willi being missed. So maybe this could be a way forward to identify. Dr. Rajib is asking why growth hormone stimulation test is not done in Prader Willi syndrome. It is not required because anyway, they will have growth hormone deficiency. If you want, you can do it, but it is not required. It's more of a pharmacological treatment. Is there any specific advice of parent to prevent dental caries? It's the usual measures, basically in terms of the intake, in terms of other routine care, which is important, but there is hypoplasia, so they will be at risk of caries, which is there. In the chat also, there are some questions. The cost of methylation study, again, 8,000 is what's there. Dr. Satyakara is asking how early can we start GH therapy in infancy? Generally, I would be a bit wary about infancy. There are some studies which are talking about, most people talk about 2 years as an appropriate age to start growth hormones. So it will be 2 years will be appropriate, I would say, not infancy. Dr. Satyakara is taking comment I would like to make is that aim for half the weight gain of a healthy infant while we are dealing with feeding issues in infancy. There can be a tendency to aim for weight gain as a healthy infant without Prader Willi syndrome. That's a very, very important point, that we should not target a rapid weight gain, because the problem is that they have failure to thrive. They are not gaining weight, and then all of a sudden you are targeting more weight and then you go the other way around. So you need to have a preemptive strategy of not allowing that much weight gain. So that's the problem. The more fat that is there in the body, you will have greater amount of appetite which is there. So it's like a vicious circle which happens. So that's why you have to be cautious in that regards. Do you use any nomogram for penile length in children? There are definite references which are available. There are charts which are available. We can share you, Dr. Pankaj, on that. At a website, along with our other rundowns and books and applications.